I think if that's all right, I'm just going to start by introducing Tim. And Arthur, if you're able to record, that would be awesome. So first of all, a huge thank you to everyone who's joined us tonight. I appreciate it. It's dinner time. We had a vision that this was going to be at the City Hospital's auditorium where we could get together and actually connect. And when we did that, that was obviously well before COVID-19 showed up. I think it's worthwhile recognizing this is the 50th anniversary for the Auckland Rescue Helicopter Trust. And certainly Tim and several of the others who are joining us tonight have had a big part of the last decade. What I was going to just describe is, a little bit about where the service has gone. And I was going to talk quite a lot about some of the new adventures, and we're going to talk a bit about pre-hospital and retrieval medicine. And obviously, Tim is our third public lecturer on this space. But there has, of course, been a change, which is why we're now doing this virtually. And so I suppose I'd just like to recognize some of the impacts this has had upon the service, but it's a global impact. And to give Tim as an example, Tim was coming to visit with his family. Although he lives in Scotland with part of his family, his sons grew up in New Zealand and consider themselves very much to be New Zealanders. I think it's exemplary not only that Tim is down here with his family, but in fact, given the circumstances, I think I'm pleased to say, has also re-registered so that he can provide care to patients in Auckland. And so I just think that's it's worth noting. By way of introduction, Tim was the guy who hired me. So 10 years ago, almost to the day, I interviewed for the position that I currently have as the medical director for the Rescue Helicopter. Tim at the time was the clinical director for the Auckland City Hospital's emergency department. And I think over that time and since then, he really has been a pioneer in bringing pre-hospital and retrieval medicine to not just New Zealand, but also to Scotland. Currently, he serves in three main roles in Scotland. So he serves as the consultant emergency physician at the Queen Elizabeth University Hospital in Glasgow. He also serves as a consultant pre-hospital critical care doctor with ScotStar, formerly known as the Emergency Medical Retrieval Service Scotland. And finally, he serves as the associate medical director for the Scottish Ambulance Service. So I'm going to be quiet, and at this stage, I'll just control slides for Tim and turn the microphone over. So thanks very much, Tim, for making time to speak with us tonight.
Great. Thanks so much, Chris. I'm just going to see, I'm not sure, is that the first slide up, Chris? I'm just going to a little check and see where we're at. There we go. Yep, love it when a plan comes together. Hey, 2 seconds just while I fiddle with the technology here. There we go. Right. So listen, thanks very much for the honour of being asked to give this talk and this lecture. Like you say, it's especially on what's the 50th anniversary of the Auckland Rescue Helicopter Trust. In this really important anniversary year. Hey, as Chris said, the circumstances of this have changed dramatically. I've not actually altered much about what I intended to say, in spite of the fact that the world's changed for us all so dramatically and potentially irreversibly in many ways in the last few weeks. I have to say, though, that giving this lecture virtually from an Airbnb to friends and colleagues does feel a bit strange. But I have put on my best shirt. I have got some cold beers in the fridge, and I fully intend to toast you all afterwards to maintain some degree of standards in these strange times. I'll probably just chat through a very personal view of where I think helicopter emergency medical systems are going and how they all integrate and what the role of them is. I'm particularly proud of my association with the Auckland Rescue Helicopter Trust. As I'm sure all of you online know, it's the oldest civilian surf rescue helicopter in the world, going for 50 years. And I actually worked with the service for less than 4% of its history. But I was part of the team in 2011 when doctors were welcomed onto the crew to add, their advanced medical skills to the Trust's long history of saving lives. This initiative, I need to acknowledge, was first led by my late colleague, who many of you know and love very, very deeply, Robin Mitchell. And then, of course, we got Auckland's own answer to Justin Trudeau, Dr. Chris Denny, who made the introductions. So this unusual backdrop to talking tonight is, of course, this COVID-19 pandemic. And I just want to use that as a little bit of context. And this is where I have maybe just altered what I was going to say a little. HEM services sometimes have, over the years, been seen as a wee bit of a luxury item, you know, perhaps viewed as a chance for doctors to fly about and fulfill their MASH or ER fantasies that brought them into medicine in the first place. But I'd like to spend a bit of time maybe setting out why I think a HEMS system is a must-have item, not just to respond to those in danger of losing their lives in isolated incidents during normal times, but also it's a must-have as part of a national resilience program, you know, when disaster strikes or when an entire health system becomes stressed, such as we're experiencing around the world just now. If I may, I'd like to use an analogy, and the analogy I'd like to do is to draw a comparison with the winch cable. The crews and the HEMS teams will be very familiar with this cable. This is the cable that supports a HEMS team member, you know, as they're lowered into an incident. This winch cable supports their life, literally. And I did a bit of reading around winch cables, and the strength of its design and its components are quite heavily engineered and designed to fulfill that reliability and life-saving function. And I think HEMS systems are the same. Of course, when I worked with the service, when a paramedic was on a winch job, they were always referred to by the crewmen operating the winch as the dope on the rope. However, I actually think that's a slightly unkind comment. And I think if you were the patient watching a paramedic being winched in to help you, then that's the hope on the rope. And in fact, I would expand that analogy a wee bit to say, perhaps for the wider community reliant on rescue helicopters to ensure they get reliable, you know, and timely medical care because they live on an island or they're injured in a remote accident or on a farm, then again, they are the hope on the rope. And I would even argue that during a national crisis such as we're experiencing now, I'd like to argue that these resilient systems offer indeed hope on a rope. Chris, could you just flick the slide for me, please, mate? This is the winch cable, and the way a winch cable is engineered is it's engineered such that there are wire strands. There are wires that are wound into strands, and the strands are then wound around a central core. The really interesting thing about the way these things are engineered is that the core is wound counterclockwise, whereas the strands are wound clockwise. That means that if any tendency for the rope to become stressed or twisted means that that as one bit of tendency for the cable to unravel, the other bit stiffens and tightens, so that any stress on a system leads to firming up and tightening of the other bit of the system to support around it. So if we relate this concept to a HEMS system, the concept of the HEMS system as a winch cable, Chris, if you could just flick on to the first animation, we've got the HEMS system is the cable. So the HEMS system is the reliable, consistent, weather-resistant, whose component parts support each other to be strong enough to lift people out of danger. And then the next one, Chris, the wires themselves are the wires themselves that form this are, of course, the staff, the different professionals that make up the system, the crewmen, the pilots, the paramedics, doctors, managers, and support teams. And these professionals are then wound into strands that form the core functions of this integrated HEMS system. And all of these are interwoven. They all rely on each other. But these core functions, I think we can break these down into three things. And again, first one, Chris, please. So the first one is rescue, removing people from danger and preventing loss of life. That indeed harks back to the very heart of the original ARHT service. The next one is clinical care. which is the, obviously the timely application of evidence-based treatment designed to save lives, but also prevent disability. And this can range from simple application of dressings to stop bleeding, right up to critical care interventions that are normally only found in the resus room. And then the fifth strand, if you like, to be woven together out of all of these component wires is transportation, which is the seemingly simple act of moving a patient or a casualty to a place of definitive care. But as those of us who work in these services know, that transportation is anything far from straightforward. We have to consider weather, the patient's condition, where the destination for the hospital is that can fulfill all of the patient's needs, and of course then the operating parameters of whatever platform you're using. And then finally, there's the central core. Chris, if you just advance to that animation. So the central core of this, I think, is what the principle that the whole service is designed around. And I would argue that works best when that has a strong emphasis on universal health care. And by that, I mean that the whole idea of having a HEMS system is to provide equity of access to high quality health care. The system should be seeking to help to minimize inequalities caused by geography, perhaps socially isolated communities, and particularly misfortune for those who suffer accidents in farms or on remote roads or even in island communities. And it should arguably, that universal healthcare, if we scratch into the definitions of that, universal healthcare is all about saving lives sometimes, relieving suffering often, and caring always. And I think it's really important that when we fly around in helicopters, we understand that is the core of what we're doing. Not just saving lives, but relieving suffering and caring for our patients. And then, of course, the whole central core, the whole universal healthcare, has to mean that a HEMS system must augment the health and social care system. And I would argue that we do that best by reducing the costly, both economic and human cost, by reducing the cost of disability, by providing early rescue, clinical care and transport. So all of these cables are strands, all these wires and strands and cables support each other. And as in HEMS, as in the wire, as in the HEMS system, I think any tendency for that wire to unravel is countered by the tendency for the core to strengthen. Sometimes in bad times, difficult operational decisions, you can fall back on that stated purpose at the core. And the core needs to resist corrosion. It needs to resist corrosion of vested interests, be they financial or driven by ego. And perhaps the worst fate for a HEMS service is for it to become irrelevant by losing its core or starting to believe its own propaganda or developing down roads which don't rely on that solid core of caring for people, saving lives and relieving suffering as part of a whole health system. Chris, if you wouldn't mind moving on to the next slide, I'd just like to then develop some of these elements a wee bit and talk about some features of that. Now, I'm just having a minor technical hitch. If you bear with me for just 1 second. I'm just going to, sorry about that. I'm toggling between a couple of screens here, so forgive me. So here we are. Yeah, so rescue. Like I said, this is one of the main strands, I think, and it's always been at that beating core of the Auckland Rescue Helicopter Trust, with its origins coming out of the surf, particularly the wild surf on the beautiful West Coast beaches. Similarly, in Scotland, there's a core of rescue that is a part of helicopter operations, helicopter medical operations, that involves around particularly the mountain rescue teams and Her Majesty's Coast Guard, which you can see there in that picture. Because there's no point in all of the clinical care in the world if we can't get the patient out of danger. On the picture on the right, those of you will probably recognize my old friend and colleague, Chris Deacon. And I probably learned more going out with the rescue helicopter paramedics and crewmen about this principle of rescue. This job, this is a still taken from one of the TV shows that involves a job I'd just like to highlight, which was at the blowhole at Murray, where the young gentleman featured there had fallen down the infamous blowhole at Murray, landed on wet sand, broke his femur, his pelvis, and his lumbar vertebrae, and had lost a fair bit of blood into his pelvis. He was lying on the wet sand with the tide coming in at a very alarming speed, with one of the surf rescue folk, one of the fire service, myself and Chris, down the hole. I had made a clinical assessment of the casualty and decided he needed intravenous lines, he needed ketamine, he needed a cervical collar, he needed a pelvic splint, and then he probably needed some fluids running because we may need to give him boluses of fluid to support his circulation as he was going in and out of consciousness with the bleeding from his pelvis. Chris pointed out to me in no uncertain terms, in words of less than one syllable, that we were all going to drown if I did that plan in the blowhole, and suggested that maybe getting us all out of the blowhole and the patient safely was the more appropriate action. And I have to say, it was a very timely lesson that I've never forgotten. Sometimes rescue comes first. Next slide then, thanks, Chris. So if we move on from rescue to that next strand, once we remove a patient from immediate danger, most HEMS operations will then seek to find a controlled, safe area where they can, perform their medical skills. And the clinical care is a real art. It needs to be gauged very carefully between doing enough to sustain life and prevent those secondary insults that lead to disability, and doing too much that just delays transfer to the patient getting to a hospital that's fully equipped to deal with their needs. And I think this balance of clinical care requires a weighing up of evidence from pre-hospital research. It requires experience, discipline, and training from the teams, but it also requires, I think, this multidisciplinary team approach that's so prominent in ARHT and other services around the world, where the doctors may decide on what critical interventions based on the patient's likely clinical course are appropriate, but the paramedics will be prioritizing the tasks and actions, and the pilots will be working out the logistics and exit strategy, as well as keeping an eye on the time and the weather. Pilots also pretty good asset for finding the nearest place to get a cup of tea and a scone with jam, in my experience. So these are some of the interventions that we might consider, and some of the ones that have decent evidence base. In the Scottish system, these interventions are graded into some different skill levels. These skill levels don't reflect their importance. They're simply a way of grading which staff members carry them out. So in the top there, we've got the green skills with tranexamic acid and splintage. And splintage not just for patient comfort and to minimize further trauma, but also to prevent further bleeding. And added to those green skills would be the use of dressings, tourniquets. This seemingly simple, but impressively effective set of interventions that the paramedics carry out. We've also then got the more sophisticated skills of more advanced analgesia, and particularly vitamin K, ketamine, for decent pain relief and sedation. And this isn't just for patient comfort, although there's some evidence, I believe, that it may avoid post-traumatic stress disorder, but by producing amnesia. But also it makes extrication more simple if the patient has their pain relieved. And then we've got our surgical interventions like thoracostomy, surgical airway, and then the real unusual high-end interventions of thoracotomy and traumatic and amputation. And then finally, we've got the red skills, the red clinical skills. These are the preserve of the HEMS critical care teams like ARHT and like the team I work with in Scotland, EMRS. And specifically, I would argue this intubation and blood are the two big ticket items, though some of those other more advanced surgical interventions that I mentioned. But perhaps even more important in the realms of this clinical care than all of these specific interventions is what I think we all know of as marginal gains. So Chris, if you go to the next slide, the marginal gains I'm talking about are where just doing things properly, consistently, and well means that you're consistently shaving minutes off the time you're on scene, and you're avoiding all of those secondary insults. You're avoiding the time that a brain is hypoxic or that the blood pressure is too low. So these next few examples are from the service I work for in Scotland, which consists of all high-risk procedures have a checklist. The one that I think you're probably seeing on your screen just now is the RSI checklist. I know ARHT is a similar one, as do most services. This checklist has been heavily modified recently for dealing with potentially COVID positive patients, with the complexities of PPE and protecting the equipment from contamination. But nonetheless, the principle still stands that no matter how urgent the situation, how big the emergency, stopping, pausing, and checklisting will actually help speed up the job paradoxically by slowing it down to check that everything's ready. The next, if you put the next animation on that slide, please, Chris, the next part of this is standardized setups. The standardized setups, again, heavily modified now for COVID, but this is our normal setup, or kit dump, where equipment is arranged around the two operators in a standardized way. And that standardized way is heavily drilled almost on a daily basis, with the crews doing things absolutely consistently. You'll have heard my colleague Stephen Hearns talk about this, about reducing the amount of bandwidth you need by having certain things like where your gear is and how you do an RSI absolutely standardized, so that that becomes the easy bit of the job. And then finally, the final animation, Chris, has got audit and feedback. We've learned a lot by using video cameras to debrief all of these RSI jobs. And this allows individuals to not only self-critique their CRM, but to also check on their BMI and how the progression of their bald patches. But the feedback we've had from this has been utterly invaluable in terms of just those marginal gains, just keeping doing basic things really well, or when you're doing complicated things, make sure they're drilled, rehearsed, and standardized. Sorry, next slide, please, Chris. So this is all well and good, but like if I go back to where we came into this about the cable and its purpose, all of this and that core of as important as the outcomes it can deliver. So those who evangelize for him services, it provided us with some ammunition to go to government, to go to funders, and indeed for where services are funded by charities, to go back to donors and say, look, this is value for money. This is where we're getting increased survival in these adult trauma patients. And if you go to the next animation, please, Chris. This was the conclusion of the paper, where essentially there was Ali Max's paper showed a higher chance to survive at 30 days, though, because in addition to the benefits of like
Just say that we've got Tim frozen. We're going to work on this. Just give me 1 sec. Again, just stay with us. I'm just going to see if I can get Tim working for us again. 1 minute.
Okay, let's just have a wee look. Are we still on there, Chris? Just had a wee warning there. All good?
Yeah, we're just a bit choppy. Maybe if you can get those teenagers that live with you just to cut down on their internet. I've just done the same, and just see if we can. We'll try and stream it. I imagine this is a busy time for the network. So
For the network. Okay, if we go to the next slide. So the final strand of that was the business of transportation. And the business of transportation is where the secondary retrievals come in. So not just that we got the primary care on scene of accidents and the rescue, but this strand of transportation. And the transportation can be as simple or as complex as you like. Obviously taking into account the clinical condition of the patient, but also like weather factors. The picture you're seeing on the left is of the EMRS team with an injured casualty from a fishing boat, rescued after the fishing boat caught fire, severe smoke inhalation. He's ventilated and he's awaiting being loaded from the back of a transport ambulance into a waiting fixed-wing aircraft in Shetland. The trouble is that there's a force 10 gale blowing outside that ambulance, and the patient can't be loaded safely until all of the airport fire engines are marshaled in a line to provide a windbreak for that patient to be unloaded. So the complexities of the transportation, even in normal times, can be significant. The picture on the left is of a Trent-class lifeboat, which is the only option of getting into the Isle of Mull, which seems to have its own particularly thick brand of fog and mist, and loading patients on and off, ventilated patients on and off lifeboats can be pretty tricky. And this whole idea of transportation requires in my opinion, the kind of professionalism and experience of people who are comfortable working out of hospital and being a bit creative with how they might need to MacGyver various situations. Next slide, please, Chris. This obviously is coming into, so this whole idea of transportation then feeds into the whole idea of where HEMS networks fit into, where that strand of transportation fits into that cable that supports healthcare systems in times of crisis. From the top picture there, that's a picture of Mike Nichols and myself transporting patients after the Christchurch earthquake with complex Takotsubo's cardiomyopathy, crush syndrome and renal failure, being moved from Christchurch to Auckland to relieve pressure on that. And the response to that event in Christchurch, coordinated by my friend and colleague Tony Smith, to that was extraordinary. Marshalling the air assets, both fixed wing and rotary, down to help out Christchurch and move patients and distribute them all around the country, provided a real model as to how these things can be done. And my understanding is that there was I watched it unfold virtually live from whatever platform I could. The response to the White Island seems to be very similar, with the HEM services being involved in both the rescue and resuscitation and clinical care, but then the onward transportation of critically injured patients to distribute them around the various burns units and intensive cares in New Zealand. Two other pictures on that slide are what my colleagues are up to in Scotland while I'm sloping around here in self-isolation in Auckland. This is them starting to move around the COVID patients around Scotland. Obviously, with its islands and its geography, some of the transfers are quite tricky and some quite long. On the right, you'll see the team using a Puma helicopter and an Epi shuttle. It's just a mannequin that's loaded in there for the time being. They've been practicing this, and I don't think they've quite ironed out all the glitches yet with the Pumas and the Epi shuttle, but that's a work in progress. And then on the bottom left is the EMRS team transporting a patient from Shetland in a large RAF aircraft. I think it's an A400. I'm not really too much of a spotter on these planes, but it's a friggin' big aircraft. My colleague who was on it said it was like being on it was more of a launch than a takeoff. But the interesting thing is that when these events happen, is how much a country relies on these HEMS teams and crews to respond to these emergencies, to provide the transport around in a critical incident. Next slide, please, Chris. So to finish up, because I realise he'd never give an Irishman a soapbox, I just want to talk through what the cross-section of the, I've been using this analogy of the winch cable, brief introduction to how this cross-section of the Scottish HEMS cable looks. At the core of the Scottish HEMS cable, that resilient core, is our trauma desk and special services desk. The trauma desk and special services desk are two dispatchers and a clinician reviewing all specialist requests for adult retrieval, pediatric retrieval, neonatal transfers, and also every 999 call in Scotland coming in gets screened for major trauma. And that desk then acts as, if you like, the universal healthcare hub and distributes the resources fairly, appropriately, and according to clinical need, and gets teams rolling to help out colleagues responding by the land ambulances. Those land ambulances are obviously providing all of those essential first steps with their dressings, analgesia, splintage, hemorrhage control, and then the various enhanced responses will get sent to support them. Next slide, please, Chris. So the next level of response is that the trauma desk or SSD can respond, is they can send what we call yellow responders, who have got those other interventions that we talked about under the clinical care of being able to give ketamine or also some of those more advanced surgical techniques. And this is provided by the basics GPs, the voluntary GPs, who are tasked to respond usually within their catchment area, and also by a number of teams of advanced critical care paramedics who are trained up to that same sort of level. These advanced critical care paramedics are based in the major hubs in Glasgow and Edinburgh, but also now based in Inverness, where they provide a significant amount of rural cover. Next slide, please, Chris. And finally, we've got our RED teams. There are 4 critical care teams, 2 of which function like ARHT and our HEMS teams in EMRS North and Scottstar North and Scottstar North and West, as you see on the slide. And they provide the primary cover, but also the secondary retrievals. The 2 other teams are a more traditional model of a response car leaving an emergency department. But it is likely within the next 12 to 18 months, depending on how the COVID thing falls out, that those 2 teams will be merged and form a 3rd EMRS team, so that for a bit of consistency. And then next slide, please, Chris. And then obviously we've got our rescue services that are interacting with them. As I mentioned, Scottish Mountain Rescue, who we work very closely with for incidents such as avalanche, and the HM Coast Guard for incidents such as diving accidents. And then, of course, all of these things interact together to provide a national resilience framework for major and critical incidents, including COVID. We've done a lot of work over the last couple of weeks, modifying the way the service responds to make sure that we're ready for the challenges of COVID in terms of pre-hospital jobs, but also in terms of these highly complex retrieval jobs. And then final slide, please, Chris. So I was thinking about this a lot, and obviously I've got have a lot of time to think. And I wonder, when the history of all this COVID stuff is written, I think there's a lot of people who come out of this crisis with a lot more respect. People who work in supermarkets, public hospitals, care workers, bus drivers, police, I think will come out of this with an enhanced respect from the public. Maybe others not so much. We'd put top of that list the airlines, but perhaps the 5G conspiracy theorists and the anti-vaxxers may have to take a back seat when all of this is done. But the HEMS systems, I think, around the world, embedded as they are, they're not a luxury add-on. They're not a luxury item. They're actually the winch cable. They are, just as these services responded to Christchurch earthquake, White Island eruption. I think the New Zealand HEMS community will form an important part of the national response to the COVID crisis, as it's doing back with the EMRS in Scotland and the various other services around the world. I think it has the strength and resilience. There's a winch cable that these rescue services form are perhaps they need to be lowered and be able to lift a nation. And I think ARHT is absolutely placed to be able to do that for this crisis and also for the next 50 years. Once again, thanks for the invitation to speak. Kia ora, and thank you very much.
Thanks, Tim. And I think one of the things challenging about the webinar is we won't be able to see everyone. What I'm going to do is I can see questions on the chat, and I'm going to ask people again. I'm going to try and open it up so people can talk. There is a feature on Zoom where people can put their hand up. I doubt that's going to work. So I'm going to try and, where possible, look for some questions. Michelle's asking, how do we clap? I think you probably just have to, you can do a wave. There's a thumbs up feature, but Tim is smiling, and when we get a chance, we'll make sure that he gets a proper celebration. I'd really like, if possible, for some questions. I had one, Tim, and I know you didn't talk about it a lot, but you did connect to some extent with the communities. And I think there are some similarities in terms of both the topography, but also the size of the population. Can you maybe just to tell me a little bit, or tell, I guess, all of us, just how the EMRS connects with their communities and the community outreach that you guys provide to your regions?
Yeah. So I was very interested in something when I spoke to you about the White Island response. There was a real echo in something that I think a couple of big incidents that I've been to is that when big incidents are happening, or big jobs are happening, or you're having a very sick patient to deal with in kind of remote and rural settings, everything relies on relationships. You can drill all that, and I'm not advocating to do anything with that. But when things are out of the ordinary or things are unusual, you do rely on relationships. And a lot of the medical retrievers from the islands have lots of little quirks or things that you've not encountered before. And so building those relationships and sustaining those relationships is, I think, part of that. If you like to continue back to the cable analogy, that's like lubricating the cable. It's kind of just making sure that that cable is corrosion resistant and well lubricated. And so what we do is once a year, the team go out, each remote area has got a liaison consultant, and they'll go out and spend usually a couple of days out on the island. Usually it involves a bit of teaching, but actually probably the more important thing is the dinner, a couple of pints of Guinness and going to a local ceilidh is probably even more important for just when you go out to those jobs. The difference, as you'll know, when you arrive into a small rural hospital staffed by a couple of community nurses and a GP who's completely stressed. And these GPs have said to us that they only stay in the job because they know that help is on the line. Otherwise, they may leave their remote community completely uncovered. So when we go out there, going out there and immediately first name terms, how are you? How's it going? Just immediately break the ice, and then we can get into the business of working together. It's this forming these ad hoc teams so much easier when you've got relationships with folk, and to use a very Celtic thing, you've had a pint with them.
Thanks, Tim. I've got a question here from somebody down in Wellington, just saying, on an average day, how many 999 or 111 calls will be received in Scotland? So that's the first part. And then, is that screening done manually or by a human, or is that an automated screen?
Okay, two really, really good questions. I think that the number that popped into my head when the question was asked was around about 5,000. Was the number that popped into my head, but I would need to just double check on that. But it's of that sort of order of magnitude, I think. The calls are currently screened manually. When I say currently, we have some issues with the guys who normally do this being reallocated to COVID tasks at the minute. But normally there's somebody there 24/7 screening the calls. They look for, they've got a really developed instinct as to where difficult bits of road are, and when they see multiple calls coming in for something, or when they see a bit in an isolated road, they look at the job. But interestingly, there's a bit of AI being looked into, where when 999 calls come in, the AI may pick up certain keywords and direct the trauma desk's attention to that. That's in a very early stage of development. One of my colleagues is working through the neural nets for that to try and identify that. But it's fully manual at the minute.
All right, I'm trying to read questions and unmute. Next question was around what in Australasia is called Prehospital and Retrieval Medicine. Again, I think globally, the EMRS or Scottstar would be seen as leading this. How did you manage to accomplish the ability to merge, as you said, these strands, so search and rescue and the pre-hospital, what we would call down here inter-hospital work? Much of New Zealand would resist that concept. So curious how you've been able to achieve that in Scotland.
Okay, so without retreading too much history, essentially EMRS came into being by a political imperative to retain medical services in remote and rural communities. So remote and rural communities were not only depopulating, but they were losing their GPs, losing their medical cover. And the GPs that were going out there were often not comfortable with some of the critical care procedures. And so there was a real political imperative. It always helps that the rural constituencies are key marginals. I'm sure Michelle will appreciate the political leverage of key marginals, but there was a significant influence from the Scottish government. They really decided that people in rural communities deserved decent healthcare, and then were prepared to fund a retrieval service. So the service came into being purely almost as a retrieval service. And then the primary work got grafted on, and that was primarily out of a relationship with London HEMS. There was a number of key personnel crossed over with London HEMS, and there was also a network of these two emergency department teams in Edinburgh and Dundee. So there was a history of pre-hospital care in Scotland. Everything just lined up and came together, where there was just the right, to again back down to relationships, the right key individuals who just saw a better way of doing this. They, in my opinion, and I appreciate that might not be opinion shared by everybody, but pre-hospital, there are more similarities between pre-hospital jobs, whether they be retrievals or primary jobs, than there are differences. So a really good example of that is the ability to operate in an airframe. I think it is really difficult to take an intensive care consultant, for example, who may be at the top of their game in their department, and ask them to provide critical care, even to a patient who normally would be well within their comfort zone, but ask them to do it in the back of a fixed-wing aircraft in turbulence with a seatbelt on. It's a very different game, I think, as we know. And I think there's much greater similarities with, I think it's environmental familiarity that makes the crossovers easier. And also, I think there's an element of that standardization that drives the primary responses is also helpful in standardizing secondary responses, in that you package a patient the same way each time, you use the same drugs each time, that familiarity. So I think it's been organic, I think is the right word to use, but built on retrieval services first. But I think there's a massive opportunity. I think New Zealand, in all honesty, needs to look at just how well it responded to some major incidents like Christchurch and White Island, to look at what is possible when you integrate your air assets and integrate them with the primary work.
Thanks, Tim. Another question here from up in Auckland. There's actually two of them that I'm going to blend. So one is around tasking, one is around coordination. Again, I know there's some work being done in the UK using video, obviously telehealth, but are you able to just offer us maybe a glimpse of where you think clinical coordination and tasking will take place, at least within your neck of the woods, so in Scotland?
Yeah, so tasking is the kind of key to any service. It's certainly the key to the primary work. There's definitely elements of having the right people doing the tasking and the right people with the right experience doing the tasking. But your question, I think, around the telehealth, there's the Scottish Ambulance Service is investing in programs that link up closely with the Good Sam app. And the hope, and it's being worked on, we've not done it for live, we've done it as tests, but the hope is that the Good Sam app will allow a member of the public to be able to send scene footage to the tasking desk, and through the Good Sam app. And then what they're able to, that will be just so much gold in terms of, because as we all know, reports from scenes are notoriously unreliable. One of the features that the trauma desk use extensively is callback. So they'll call back the person who made the original 999 call and say, we're not delaying help is coming, but I need you to talk me through so we can work out, just walk me around the scene and describe each of the patients to me. We had a very big, a car drove into a group of people on Boxing Day with 5 category 1 patients, mostly young people. And the scene call from there, we just got a brilliant person who just gave us virtually an Atmos handover for each of the casualties, which was obviously invaluable.
Almost caught up, and I'm mindful of the time, so maybe just take a couple more questions, but would really encourage people. It's quite easy. Arthur's been superb here. If you want to either type into the chat or there's also a question and answer form, and we'll try and scan both. This is around, I suppose, looking over the horizon, and often the pilots will tell us that it's important from a situation awareness standpoint to just get ahead of where the plane is flying, or for our case, clinically, where the patient's going. What do you see? I mean, we've had 50 years, the Auckland Rescue Helicopter Trust. The question specifically was, what do you anticipate over the next 50 years? Now, I think that's a bold question. Even if you gave us 5-10 years out, where do you think pre-hospital retrieval medicine, where's it going?
I think it's going to be increasingly, and the college have recognized this, I think it's going to be increasingly recognized as a discipline with its own training needs and requirements, its own key core skill sets and experience space. So the college has made a major step in Australasia towards recognizing that with the training schemes. So I think we'll see it. It's almost like the early days of intensive care or the early days of emergency medicine. I think we're seeing the burgeoning of a specialty. I think as that happens and grows and we get more and more talented folk into it, and the old bodgers like me suddenly, start leaving it to the new folk, I think we'll get a fresh blood into the service. And I think some of these issues will be pushed along by enthusiasm and positivity towards integrating the primary and secondary retrievals. It does not make sense. I have to say, it does. National coordination, I think, is the right road to go down. And maybe, when we all come out the other end of COVID, the idea of cooperation and collaboration rather than just protecting your own little service will hopefully be one of the legacies of it. Who knows? But I think that's the way I hope it goes. If that's not, I'm cynical enough to have seen this falter several times in New Zealand and in Scotland, where patch protection spoils what needs to be collaboration. But everybody's got to give a wee bit of turf, right, for it to work. But I think the key will be training up new specialists, developing it as a specialty, and having them enthusiastically push for the development of it and push for it to be a national thing. Because at the end of the day, like I was saying about the cable analogy, this is what a nation will depend on when bad stuff's happening, is this integration and coordination of its pre-hospital assets to get people to hospital in a salvageable state.
Thanks, Tim. I'm just looking to see if there's any last questions. So options include, I think you can virtually put your hand up. You can type something into either the question and answer or the chat. My final question was actually a question around culture, which I guess I've certainly, in my role, had to explore a lot in the last 5 years. I had the privilege of working with you when you were the clinical director of our emergency department. Certainly now, your reputation with the Scottish Ambulance Service and with Scott Star, continues to resound. So how do you sort of nurture that culture? I know that's a massive question, but are there just a couple of things that maybe in your time traveling the world you've seen, or some ingredients that maybe we can try and nurture in these sort of dark days in front of us?
I think the word that comes into my head is maybe just is for services to have a bit of humility, and realize that they are not perfect, they're not heroes, they are professionals doing a job of work, and that job of work has to produce results. They have to be judged on results. So I think having a results and outcomes driven culture, and having the humility to admit that you're going to have to keep changing, keep developing, and you will never do the perfect job. And I think the badge camera technology is very, very, very powerful in doing that. I watch reruns of my jobs watching the badge camera and just say, would you please just shut up, because I talk incessantly. But it's very instructive, because things you think that you do, you don't, you may not do. And I think, having your peers look at that, and living within a culture, if you like, that's confident enough for you to say, like I did a pre-hospital thoracotomy recently on a stabbing victim, and I showed it to a couple of my peers, and 2 or 3 of them said, yeah, that's not the way I'd do it. I would have done that, that, and that. And actually, I think now the service is mature enough, and hopefully I'm old enough to regard it as a mark of respect that they would tell me that. They want me to be better. And I think that's the thing, is that critique is people wanting you to be better. It's not them having a go. And I think that's the culture that's so effective.
All right. Well, I think we should give you a break, and I think equally we should let people get to dinner, to their other activities, as constrained geographically as they are. So I suppose on behalf of our service, it's not the way we'd hope to welcome you back to country. I'm certainly hoping you're able to work a few shifts with us in the emergency department before Her Majesty steals you back to Great Britain. So on behalf of all parted, at some stages we've had close to 50 participants, just like to say a huge thank you from all of us.
Oh, thank you for asking me.
All right. And so with that, we'll sign off for this webinar. A huge thank you to Michelle for actually buying into this audacious idea, and for Arthur for helping us to execute. Big thanks to Tim, and all of you, go safely. Please take care. And Tim, maybe if you stay on just for a minute, we'll debrief this, and
Sure.
We can look through the chats, because there's a lot of nice words coming through for you. We'll just let people sign off and go safely. Now, Lad, can you see the chats?
Yeah, just pull them up.
And Arthur, I think you should be able to hear me, but that was just a massive help, Lad.
No worries.
I felt like one of those disc jockeys when you're a little bit out of step the entire time. It wasn't a particularly comfortable feeling. So grateful for you being able to sort of guide me to where, look here, look there, let's keep it in order.
I reckon you nailed it.
Now, can we turn the recording off before we say anything that we're going to regret?
Yes.